some pills can cause gingivitis. Stress, vitamin C deficiency, so scurvy. Not seeing a whole lot of that lately. People are pretty good about their vitamin C intake. With hormones, and I'm just going to put this out there for all you parents, teenagers are gross. So I remember sitting down with my kids and being like, look, it's time we had a heart-to-heart. You stink. Showering and bathing is no longer an option. It's going to happen daily. I don't care if you prefer morning or night. That's fine. Take one or the other, but every day you have to shower. And brushing your teeth is not an option. Like, you cannot decide that you're too tired and you're not going to brush your teeth. Every day you have to brush your teeth, morning and night. What really kills me is the kids that don't want braces. Teenagers, and I hate to throw the guys under the table, but usually it's males. The parents want the braces more than the kid. So you have this kid that's non-compliant in orthodontic treatment with braces, going through puberty, hormonal, not brushing their teeth, and it's just terrible. So let me lock this memory in for your mind, because it's already locked in mine. We had someone come back from the orthodontist. They were not taking good care of their teeth. And when they took off the braces, there's a bracket removing tool that you place on the bracket and you kind of close, and it crunches the bracket cement off. Well, when they did this, his tooth was so rotten that they were trying to remove the bracket, and they removed more than half the crown of this kid's tooth. So he had very straight teeth. They were covered in cavities, and pieces of the teeth were missing. It's just not worth it. So if you're wanting to put your kids in braces, just think about that. Like, make sure that they're on board, that they really want it, so that you don't have straight teeth that are rotten. But yeah, puberty can make it worse for sure. It can cause swelling of the gums, cause gingivitis. Local factors, this is a great reason to get braces. If you have crowding, if you have food traps, braces will straighten that out and get rid of that. Cavities are just, think of it as little local areas that harbor bacteria that can cause gingivitis as well as decay. So if you have cavities, you're more prone to get more cavities and to have issues with potentially with gingivitis. Frenum attachments. Have I talked to you guys about frenums yet? Frenums are the muscle attachments in the mouth. So when you lift up the gums, you'll see like a strong muscle attachment. That's the frenal attachment. Sometimes it goes all the way down close to the teeth and can cause problems. I'll try and find a picture of that in one of the slides coming up. Overhanging restorations, yes, and orthodontic appliances. I already talked to you about that. Where the orthodontic appliance is placed, usually it's close to the gums, but not on the gums, not on the gingiva. But if you get gingivitis, all of a sudden, you'll see the gums swelling up over the ortho brackets. So orthodontic appliances can cause gingivitis because it's hard to brush around. All right, next slide. We're on 14, treatment of gingival disease. Take a look at that. Too easy. Get a cleaning at your dentist, brush and floss at home. Next slide. Toothbrushing technique. If you ever want to impress a dentist, tell them that you use the Bass Sulcular toothbrushing techniques, or the modified Bass is another favorite. Basically, all that the Bass toothbrushing technique is telling you how to effectively remove all the plaque by holding the toothbrush at a 25-degree angle and doing lots of strokes directed into the sulcus and then away from the sulcus. And you want to do short, vibrating, overlapping strokes. Repeat at each position. Now, when I say repeat at each position, take a look at the next slide, slide 16. Look at how many different angles you have to hold that toothbrush. For the Bass Sulcular toothbrush technique, it's our accepted way of doing it. Repeat at each position, repeat on each arch. It takes forever to do this with the manual toothbrush, forever to do it right. Every time I go camping, I stick, or backpacking, I take a toothbrush and I don't bring my electric, and I miss my electric because I'm sitting there as a dentist doing it and thinking this is BS. This is taking way too long to sit and brush each tooth. So I've had a couple people ask me about this. What do I think about electric toothbrushes? I love them. Absolutely love them. You want to take your relationship with your significant other further, go ahead and get that 2-pack at Costco or Sam's Club. There's no greater way to say I love you than to go ahead and grab that electric Oral-B and share it with someone. I don't like the Sonicare as much as I like the Oral-B. The Sonicare toothbrush head is too large to get all the way behind that second and third molar. But the Oral-B is a small, round toothbrush, exactly what we use for prophylaxis. So obviously they were marketing it towards dental professionals. That Oral-B Professional electric toothbrush has a timer, so it goes for 2 minutes. It has a pressure gauge, so like if you push too hard, it goes and it turns red. It'll tell you how long you're brushing. You just kind of put it on each tooth surface and let it sit there for a few seconds. It's amazing. So it'll make your appointments at the dentist quicker and easier. And big fan of the electric toothbrush. I see a question popped up. Does the shape of the toothbrush head matter? Yeah, it does. So the shape of the toothbrush head matters because everyone's mouth and teeth are different. The smaller your mouth, and think about children and adolescents as well, you want a very small toothbrush head. And for some people, in order to get all the way back behind those back teeth, you got to have a small head, and then you have to teach them to brush with their mouth closed, because when you open, your condyle of your jaw is going to block getting all the way back there. So some people have very large mouths, and the toothbrush head doesn't matter as much for them. But what I've seen is a smaller head is better because you can get in more difficult areas. What's the benefits of different pressure? Well, let's put it this way. If you break a glass on the ground in your kitchen and there are glass shards all over, doesn't matter how hard you sweep or what you're sweeping with, or the movements of how you're sweeping. I think if you sat with the broom and you pushed really, really hard with the broom, I don't think you're going to sweep necessarily better. You want enough pressure to contact the surface, and the movement's going to be very important, how you move and get all that glass up. So if you do too much pressure, those bristles will wear out quicker, and you'll also probably wear against the surface harder. So in your mouth, if you apply too much pressure, you can actually cause erosion. You know how we were talking about acid erosion on teeth? It's not called erosion when you do it with the toothbrush. It's called attrition. But you can cause that by brushing too hard. So you don't want to do too much pressure. You want light pressure. And it's all about the time and the motion rather than pressure. All right, so we hit the Bass sulcular technique. We talked about how that's a great way to reduce gingivitis. Any other questions or concerns from anyone? I got one more slide, and then we're going to go to questions, and we'll take a quick break. So this last slide, this is where I, looking at slide 17 before we get done with this part of the lecture. We say brush twice a day for 2 minutes. That's big ADA. That's the American Dental Association, because they don't have belief in the general public. They know that y'all ain't brushing as often as you say, and you're not doing it as long as you should. And so they do twice a day, 2 minutes of time. It's not really necessary. I know. Don't shoot the dentist. If you were to brush once a day for 2 minutes and be thorough on it, I would sleep very well at night. So let me put this out to the public chat. Brushing once a day, when would you rather brush, morning or night? When's the right time to brush if you're only doing it once a day? Nighttime. I see everyone hitting night, 100% right, nighttime. So if you can go to after the last meal, perfect. So if you do this before you go to bed, you're in great shape. And I have a hard time brushing for 2 minutes. I'm a dentist, and I do not like brushing for 2 minutes. Like even with my electric timer on, I'm like, Jesus, this is long. So if you're going to brush less than 2 minutes, brush twice a day. If you are a thorough brusher, once a day is probably enough at the end of the day, right before bed. All right, now flossing once a day. I'm going to go ahead and say it. Man, if you floss every other day or a couple times a week, you are doing great. You really have to do it every day. And again, I love electric toothbrushes because it's going to knock everything out interproximally. It's going to really help you. So some people absolutely need to be flossing more often if they have that caries risk and everything going on. In general, you know how I know when to floss? It's because something's stuck in between my teeth. So if I eat ribs, if I eat meat, like if I eat popcorn and I know I got popcorn kernels or chia seeds all over, I'm going to floss. But it's not necessary every day. Again, ADA recommends once a day. If you're going to floss, will you floss before you brush or after you brush? Give me some thought process on this. Would you brush first and then floss, or would you floss first and then brush? And why? Why would you? Okay, I see a lot of people are saying before, floss first, good. Why would you floss first? Yeah, so I see a little bit before and after. Most people are saying before, some are saying after. some say only to get compliant from the dentist. Yes, excellent answers. So as a dentist, here's what I'm going to go ahead and tell you guys. Most of you are right. I would floss before. And the reason you floss before, because you're going to drag stuff out onto the tooth surface when you floss. So if you floss before, you're loosening the debris. You're bringing everything that's interproximal in between the teeth out onto the tooth surface. And then if you brush after, you're then removing everything that you brought out onto the tooth surface. And as you floss, you want to walk that floss so that you're not just using the same piece over and over again. Tighten on one finger, loosen on another, and walk it. And then tighten on another, loosen on another, and walk it around, or rinse it off under the running water so that you're not just reinfecting with bacteria from the same piece of floss over and over again. So the right order, floss first, then brush, and then if you're going to use a mouth rinse, use a mouth rinse. Is floss better than a water pick? I mean, if you're using a water pick, I'm just happy you're thinking about it. But anything that a water pick does, floss will do and better. So a water pick helps, but floss is better. What about those little floss picks? Floss picks are great. I love people who use them. I find them on the floor every now and then when I'm walking around outside, and I'm thinking somebody is caring about their hygiene, and it warms my heart just a little. Are flossers as effective as using the floss around your fingers? Yeah, I think they are pretty much just as effective. The hard thing is with floss around my fingers, I can shape it so I can kind of hug one side of the tooth and then hug the other. With a flosser, it's a little bit more difficult to do that. So I've never seen electric floss. Electric floss sounds like a sweet name of a rock band. All right, hey, yeah. No, you guys are probably doing better than than people are telling you. Let me just go ahead and say, take a 10-minute break. We're on slide 18. I'll stick around and answer questions, then we'll move on to the periodontal disease process next. So go ahead and take like a 10-minute break. I'll see y'all back at 14:05, but I'll stay here and answer questions, okay? All right, heard to leave toothpaste on for 5 to 10 minutes after brushing and before rinsing. Okay, so cool. Yes, so if your toothpaste is high in fluoride content, you want to leave it on and not rinse it off. So if you have been prescribed toothpaste like Prevident, then yeah, I would recommend you leave it on, spit out, and let the residue stay on your teeth to help that remineralization process. And I'll even do one better. If you have sensitive teeth or an area of concern, you can squeeze a pea-sized amount of toothpaste onto your finger and rub it against that area that's sensitive or that has a concern. And then just spit the excess out, and just let it rest against the tooth. It'll aid in remineralization. It'll help strengthen and desensitize that area. But yeah, good question. So yeah, you can leave fluoridated toothpaste on, especially the prescribed fluoride. It'll help strengthen the teeth. If you're doing fluoridated toothpaste and then you're immediately rinsing out with mouth rinse, whatever's in that mouth rinse is really going to be the thing that's benefiting your teeth. You're not getting as much benefit from the fluoride. So for kids, while I have you all here and you're enjoying your break, for kids, if you're doing ACT toothpaste with fluoride, that should be the last thing that they do right before bed. And you can floss, you can brush, you can give them a glass of water or whatever else they want, but then you have them rinse out with that ACT fluoride mouth rinse and spit out, and do not have them rinse with water. Do not have them drink any more water. You want that to just rest against the teeth. You want that substance to be in there. Oh, you're going to love my recommendation for a bedtime snack. One of the best things you can eat is cheese. So cheese and milk are excellent for your teeth. Now, I wouldn't eat it and not brush and not floss, but yeah, cheese and even fruit. Like if you eat apples, the mechanical action of chewing on an apple or a carrot helps clean your teeth. Think about like those dog biscuits you give to your dog. It's like, hey, this is going to help clean the dog's teeth. How does it help clean the teeth? It's the mechanical action of chewing that helps clean. Something else, hello, dentist, this is what we added to the MRE, xylitol chewing gum. You guys, that chewing gum in your MRE, that was the dentist that added that. And because xylitol is a non-fermentable carbohydrate, you can't process it. So if you eat your MRE and then you just chew that you chew that gum, it's going to help clean your teeth mechanically, and it's going to put xylitol in your mouth that is non-fermentable carbohydrate. It's going to help protect you. So that's another thing that you can do is, and you'll know which ones have xylitol if you pick out gum off the counter, because it'll have the ADA seal of approval. It'll say ADA approves this Trident. ADA approves of what, yeah. And that's because big ADA likes the money. So their seal of approval is, do you have xylitol, and are you going to pay us $500 for our seal or whatever? You know, so then you get the ADA seal of approval. Good question. Yeah, so ending your meal with cheese, if you're not going to brush after, is good for you. Yeah, absolutely. You're spot on. Long live the French. They figured this out long before us. No meal is complete without cheese in France. Let me just kind of scroll back through and see if I missed any questions, but y'all enjoy your break. I'll be here. We'll start chatting again in a few minutes. All right, we're going to go on and talk about periodontal disease next. And the question that typically comes up in questions about gingival diseases is gingivitis can progress to periodontal disease. So it's typically a precursor. But if you look at gingivitis, if we resolve the gingivitis, doesn't progress to periodontal disease. It doesn't impact the bone, and you can have gingivitis and really return to a complete state of health. Once you have periodontal disease, it's a little harder, and it's like kind of a lifelong thing. In the dental community, we'll call it gingival health with a reduced periodontium, because quite often, if we work on the periodontal disease and get it fixed, it's never returned to what it was originally. There's always an impact. So just kind of think about that. We're going to move on to slide 19, oral disease process, periodontal disease. Go ahead and hit slide 20. All right, so gingivitis has the inflamed soft tissues. So it includes the epithelial and connective tissues caused by bacteria typically. Periodontal disease is inflamed soft and hard tissues. So that is the big, big difference. And with our gingival disease, it's usually a little bit more of the aerobic gram-positive, whereas with periodontal disease, you'll see anaerobic and gram-negative much more frequently. With our periodontal disease, there's an inflamed PDL. That's the periodontal ligament. You'll see mobility, a widened periodontal ligament, so the teeth are loose. Sometimes if there's a bad overhang on a restoration, a crown that's too fat and fitting wrong, it can cause localized areas of periodontal disease. Most common, though, is bacterial. Again, with periodontal disease and with an inflamed PDL, we can reverse the inflamed PDL, get the PDL back to normal. All right, next, slide 21. Periodontal disease is the #1 cause of tooth loss in adults. So slight foot stomp on that. That's an easy one to remember. #1 cause of tooth loss in adults, periodontal disease, often undiagnosed. So kind of like high blood pressure or diabetes or hypertension, other things that so many people have and are unaware of. Periodontal disease is always preceded by gingivitis. In periodontal disease, there's an inflammation of the gingiva, the PDL, the bone. The bone's affected as well. With the disease state, the full tissues will be inflamed, the PDL will be loose and wide, increased probing depths, and you'll see the alveolar bone resorbing. I've got some examples of that coming up. And just remember that periodontal disease can be managed, but again, the damage becomes permanent. So that's the hard thing, is once you have periodontal disease, that pocketing and bone loss, even if we get you back to a state of health, you'll still see a reduction in the bone height from where it should have been. Slide 22 shows some good examples. Foot stomp on this, 3.5 millimeters, healthy periodontal pocket. So if I stick a probe in there and it slides bigger than 3.5 millimeters, then I know that could be gingival disease, could be gingivitis, but it's a sign and an indicator of diseased tissue. And quite often that's what we look at with periodontal disease. So if you got healthy gingival probing depths, it will be 3.5 millimeters or less. So remember that number. With inflammation, you get a migration of the junctional epithelium from the cemental enamel junction, that's the CEJ, the cemental enamel junction, and you get a loss of attachment. But as the gums kind of recede, but they're following the bone. Because the bone's being eaten away, the gums shrink and follow them down as well. Next slide, on slide 23. You can see, again, I think I'm foot stomping this. Untreated gingivitis can advance to periodontitis, which leads to deep pockets and bone loss. Cool picture here. You can see the calculus, which is hardened biofilm. You'll hear some people call it calculus, some people call it tartar. So that's just sitting there irritating the gum tissue, and the bone starts to shrink away as a result of the calculus and bacterial toxins. So you can see, and as the bone shrinks away, do you see how much of that root is left anchored? CEJ is cemento enamel junction. I see that in the chat. So it's where the cementum and the enamel meet, is the CEJ. Slide 24. I don't want you to worry too much about the classifications of periodontal disease. Yeah, you're welcome. So the classifications of periodontal disease, just know that there's slight, moderate, severe. They have new ways of talking about it every year. The periodontists get together and have a meeting and come up with new ways to classify it. But in general, you'll see gingivitis first, progressing to slight periodontal disease with a little bit of attachment loss, which is usually defined as 1 to 2 millimeters. Moderate is where, 3 to 4, maybe 5 millimeters of loss. Severe periodontal disease, extensive loss of bones. You're getting into the furcation, which is where the roots are in the bottom of the teeth. You can see between the roots of the teeth, lots of mobility. So with severe periodontal disease, often it leads to extractions. We're on slide 25. Early warning signs. So clinical signs of gingivitis, it's the early warning sign. Probing depths apical to the CEJ, that's that cemental enamel junction. Most of the time, your gingival tissues will attach right at the CEJ, right at the crown of the tooth, so that you don't have any exposed root surface, no exposed cementum. So when you start probing and you get below that, you're on the cementum, then you know that you're below the CEJ. Radiographic evidence of bone loss, and I'll show some pictures of that. Tooth mobility and migration of the teeth means the teeth start to move. They start to shift right, left, up, down. All right, so here's a good example on the next slide of what periodontal disease looks like on x-rays. So that one on the bottom right, can you see that pocket? And the space in between the roots, that's the furcation. So there's furcation involvement. One root, and if I'm using my terms, you've got the distal and mesial. Mesial is further forward, so that it's the mesial root of this tooth, this molar, that is just deeply impacted by periodontal disease. But I don't want you to think the rest are okay, because that bone is flat and it's more apical than normal everywhere in this mouth. If you look at the picture on the left, looking at someone's mouth, again, you can see the recession. You can see the buildup, the plaque, the bacteria, some tartar or calculus that's in there. Some of those teeth might be mobile. If I were to try and wiggle them, they might have a little bit of movement to them. So signs and symptoms, mobile teeth. Mouth sores and purulence, that means that when I'm probing, not only do I get blood coming out when I'm probing, people with periodontal disease, often you'll have pus come out. So I'll probe and I'll get a little purulence, a little white coming out of the pockets, which let's just take a pause and just think about that. If I were to touch anywhere else on your body and tell you that pus was coming out, wouldn't that freak you out? Like, I don't know why people think it's okay and normal for pus to come out from around their teeth. So with periodontal disease, they'll tell me sometimes, yeah, I get a bad taste in my mouth around this tooth on occasion. Yeah, that's the pus coming out from the infection, the periodontal disease that you're tasting. So pretty terrible. Radiographic evidence of bone loss, we already talked about that, and I showed you a good picture down there of what it looks like. Halitosis is just a fancy way of saying bad breath. So periodontal disease stinks, and if you smell it often enough, you'll be able to smell it on someone when they're talking to you. If they have bad advanced periodontal disease, you can kind of smell. Blunted interproximal papilla, that's, take a look at this picture on the bottom. You don't see knife, you don't see the interproximal, you don't see knife edging. It's just kind of flat. Instead of normal papilla that are up and look kind of triangular, they're just gone. Destruction of the attachment apparatus, all good there. Slide 27 is another picture between the healthy and the periodontal disease. I think we've already hit this a couple times now, so you guys know what we're looking at. Slide 28, causes of periodontal disease. Plaque and calculus formation, number one. Traumatic occlusion, if you have a tooth that gets hit first before every other tooth, it's in the way, it will cause bone loss and periodontal disease. So if you ever get a filling or a crown or something done in your mouth and it doesn't feel right, you feel like your bite has changed, go get it looked at. Because if you just keep biting until it feels normal again, sometimes you're wearing away a little bit of the bone or the tooth. Poor hygiene can lead to this. Smoking and tobacco speeds it up. Again, hormonal changes can cause this. There is genetic predisposition to periodontal disease, especially juvenile periodontal disease. People who get it before 18 are more genetically prone. Stress, yep. Medication, clenching and grinding, diabetes. I think diabetes is a risk factor for just about anything. Diabetes just causes a decreased wound healing across the board. Everything heals slower. So even if I'm doing extractions and taking out teeth on a perfectly healthy person, if I know they have diabetes, I'm more likely to prescribe antibiotics. Like most people, I'm not going to, but for diabetics, I just know it's going to be a lot more comorbidities and a lot more problems. Poor nutrition, yep, can lead to it as well. All right, moving along, periodontal disease. Let's talk about therapy. Most common is non-surgical therapy, which is a good deep cleaning. So we'll call that supra, which is above, and sub, which is below. So we're cleaning above the gingival surface and below the gingival surface by scaling and root planing. It's either done by a dentist or by an RDH, a registered dental hygienist. Most of the people who clean our teeth in the military facilities, even me when I go, it seems like they're FDAs or are military trained hygienists. It's not very often I get to see an RDH. So just be aware, if you have periodontal disease or gum disease, you want to be seen by a registered dental hygienist, and they should be making that happen at the dental clinic. If you have good hygiene, if you have not a whole lot of buildup, then you'll get, a military trained hygienist. They're called dental X2s, preventive dentistry specialists, or an EFTA, expanded function dental assistant. They'll do the cleaning. For non-surgical, we'll place antibiotics directly into the pocket sometimes. There's chips that have the antibiotics in them that you can place, perio chips. We talk about diet, rest, reducing your stresses, and elimination of smoking helps for elimination of any traumatic occlusion. For surgical intervention, this happens with a deeper, more progressed periodontal disease. And guys, I'm here to tell you, it's barbaric. I've had to do it on a couple people. It's not a lot of fun. We literally make incisions on both sides of the gum tissue, on the buccal surface and lingual surface, kind of going around the teeth, and then we just fillet it back. We scoop that gum tissue down off the bone on both sides so we can look at where the bone is and where the teeth are and clean out all the bad bone, reshape the bone, clean out all the bacteria, tartar, and calculus, and then take this gum tissue, bring them back up, and sew them back together. So that's the surgical intervention. Necessary, yes. Fun, for no one. And we now have a LANAP procedure, which is a laser that can go in there and can do it a little bit. The studies that I'm seeing show that it's pretty darn good, but the laser therapy is a lot less barbaric. So just so you're aware, surgical intervention, I would say laser is still a non-surgical therapy because it's not as barbaric. But yeah, no fun. Slide 30. Okay, so for you, if you were to do an assessment and try and find periodontal disease, the main thing is in an assessment, you're not given the diagnosis. You're looking at it and you would know, I mean, if you had a probe with you and you probed, all right, you're getting probing depths deeper than a 3.5. If you get any probing depth anywhere in the mouth deeper than 3.5, that's an area that we want to look at. The way that you could perform your assessment is based on looking in the mouth and seeing the plaque, the tartar, the calculus, the recession. You could smell it. You could smell the halitosis. So you're going to see some signs and symptoms. You'll see the redness. You'll see the swelling, the edematous. Maybe even you can tell that the teeth are mobile. Those are all signs. So you would say, hey, I think that, you know, you can review hygiene with them. I talked to you about brushing techniques, about flossing, all these things I'm telling you so that you can share them when you have a patient. But the diagnosis is typically given by the general dentist. And then the diagnosis is confirmed and the treatment is monitored by a periodontist. Our periodontist is our gum specialist. So our periodontist does all the gum surgeries. Think of them as like plastic surgeon for the mouth. That's our periodontist. They're really good at implants. They're really good at treating periodontal disease. And the registered dental hygienist will help. All right, so periodontal disease. One reason I want you to be able to kind of assess and tell that these people have something crazy going on in their mouth is if you ever intubate. Yeah, so there's some bad stuff that happens when you intubate people with periodontal disease. Can anyone think, go ahead and put on the chat something that might something that might occur in a periodontal patient? Cards. Knock teeth out, correct. Cool. So yeah, those teeth are mobile, super easy to knock out. Hey, someone got it. Nasty pneumonias. Yeah. So all that plaque and biofilm that's on the people's teeth, you're dragging down when you intubate into their lungs. So you can actually get a really nasty pneumonia. I'm proud of you guys. Excellent job. You're spreading the bacteria. You can actually knock out a tooth. All that stuff happens way easier in someone with periodontal disease. So if if it's an elective surgery especially, yeah, aspirate, exactly. They could aspirate a tooth. It could get knocked down and they could aspirate it. Good job. So just kind of think about that. And if it's an elective surgery, man, you want to treat the periodontal disease and everything first. All right, so let's go to the review on slide 31. Is gingivitis the same as periodontal disease? And the answer is no. Go ahead and hit slide 32. Gingivitis only involves the soft tissue around the teeth. Periodontal disease involves the hard and soft tissue, to include the bone and PDL. If gingivitis is not treated, it will or it can progress into periodontal disease. So not the same thing. Number 33, slide 33, what is the primary cause of plaque-associated gingivitis? Well, I gave it away in the name. Plaque-associated, so it's plaque, it's bacteria. Colonies of bacteria form a biofilm, plaque, which then can produce that chronic inflammatory disease. Slide 35, what is the first step in plaque formation? Y'all remember this slide from yesterday that I foot stomped on, or on Friday? The first step is, go ahead and hit the next page, next slide, 36, formation of the dental pellicle. That pellicle has to form. And the pellicle is great, right? Lubricates, it makes everything nice, keeps it nice and moisturized, but it also, unfortunately, is the primary site of attachment for bacteria. Slide 37, what is the cure for gingivitis? Pretty easy, we got to remove the plaque. So slide 38, remove the plaque. Be a good home care. That's why we talked about flossing, brushing, use of mouthwash, and see a professional. So, Again, in the military, we're going to see who we're going to see. But yeah, registered dental hygienist is the best every 6 months. Another review here on slide 39, 4 cardinal signs of inflammation. Can you name some other characteristics of gingivitis? So aside from the 4 cardinal signs, we got the answer on slide 40. Loss of stippling, it turns shiny, bleeding on probing, purulence, receding margin. Excellent. All right, so this is the kind of question on 41 that I try and write at least occasionally, so that you can get an idea of what to study for. So question on slide 41, a patient presents in severe pain. Chief complaint is that he can't chew. He indicates that due to stress in his life, he's smoking a lot more. You notice rampant decay, blunted, punched out papilla. You want to be professional, but man, you're stepping back because he's got fetid odor. What do you suspect? And that would be ANUG. Acute necrotizing ulcerative gingivitis. Necrotizing ulcerative gingivitis. Any other questions for me? You guys ready to just power through the last section? I think we're about more than halfway through the slides today. All right, everybody, I saw a million thumbs up, like a flock of birds just shooting out of the, all right, we're going. So, feel free to ask questions, and I'm just going to say water picks. Water picks are helpful. I've had a couple people ask about water picks. If you like a water pick, go ahead and use it. Now, if you have implants, you want to be careful around the implants not to damage them. And a water pick is very gentle. So sometimes I'll get questions about implants and water picks. Yes, absolutely. Use a water pick around an implant. It's going to help because it's going to irrigate, and it's like, God, I wish I could give a better example, but first thing that comes to mind is if I step in dog crap when I'm walking outside, if I get the right pressure on the hose, I can shoot it off of my shoe. Now, I'm not going to eat off of my shoe afterwards, but I can debride and get most of it out. And that's kind of what a water pick is. All right, you're shooting, you're pressurizing, you're irrigating, you're removing the debris. But if you really wanted to clean it, you would want to get someone to scrape it off. That's what the hygienist is going to do. They're going to have that tools to go in and mechanically scrape it as well. But water picks are excellent. Go ahead and shoot any questions that you have in there. We hit gingivitis and periodontal disease. Now we're going to talk briefly about dental emergencies. I'll answer any questions as they pop up in the chat. So I wanted to talk to you briefly about the DoD dental classification system. So go ahead and look at class 1, class 2, class 3. No need to scroll slowly. Let's get to slide 48. So here's my question for a test. It would be something like this. Which dental classification is the least risk for a commander? The smallest risk? Go ahead and throw your answer up there. Excellent. 1, 1, 1, 1, 1. Good. So 1 is the lowest risk because they have no dental. And I want you to picture, it's rare. It's rare that someone has dental class 1, but when they have dental class 1, they don't need a cleaning, they don't need an exam, and they don't need any treatment. They don't need any fillings or anything. So they're perfect. It's Jesus himself blessed me by coming to my clinic. I looked in his mouth, I gave the thumbs up, and I said, class 1, we're good to go. It is rare, but it happens. Class 2 is the most common in the military. Class 2 is super common. You need a filling, you need one cleaning, you need a crown. Class 2 is routine. I don't expect it to become an emergency. Class 3. So here's my next question. Class 3 and Class 4 are both, in theory, non-deployable. However, that's all changed. Now they're deployable, but not medically ready. So Class 3 and Class 4, which one's the higher risk? Good job. Jesse got it right. Bradley, good job. Class 3 is the highest risk. Class 4 is, I don't know what's going on. I haven't seen you in your mouth, so you could be really high risk as a Class 4. I just have no idea because you don't have an exam. So statistically, if I look back at the data, every Class 4 that I see, it's somewhere around 10, 15% that convert into a Class 3. So Class 3 is the highest risk because I look in that mouth, and this is what I want you guys to envision. Class 3 is the dentist cries when he looks in the mouth. He says, "Are you in pain? Because you should be." That's what a class 3 is. You should be in the chair getting worked on now. Zachary, there's nothing else I can teach you. You have learned it all. It depends is the right answer. Okay, so so class 3 is the highest risk. Class 4, I don't know. You need to come in and get a dental exam. But a good, 10-15% of those class 4s will turn into a class 3 and be high risk. Go ahead and look at slide 49. I took this from Japan. I like it because it's easy to see. They have the green, yellow, red. So it's really easy to see. Class 1's the easiest. It's ready. It's deployable. Class 2, and this is something I'm trying to get across to you guys because I've seen people get really upset. I'm dental class 2. I'm good to go. No, you're dentally ready, but you're not dentally well. So it's something I've been trying to explain to senior leaders and to others in the military. Dental wellness is dental readiness. That's a dental class 1 is dental wellness. That's the best you can get. But we stop at dental class 2. Class 2, good to go. No worries. Let's move out. And we're doing a disservice because we don't think there's going to be an emergency, but what's going to happen to that cavity downrange when it's a small cavity right now? Their hygiene gets worse and they're sucking on Rippets all day, rinsed out with a glass of Gatorade and followed up with, gummy bears and tobacco. Like that thing's going to grow like mad. So class 2 is not as good as class 1. Let's go on to slide 50. All right, so why is it important? This is how you try and relate it to the people that you're working with in the military. Dental classification is readiness and deployability. Here I have it listed about 10% of all class 4s become class 3s. Dental readiness is a way to reduce risk. And then another reason that I want you all to care is who's going to be providing these dental services at a roll 1. It's going to be you. It's going to be maybe our whiskeys helping you out. So class 1 are the most likely to be good to go and to not have dental emergencies. Here's some examples. Go ahead and get on slide 51. This is perfection. Look at these pictures. My God. I think this has to have been an orthodontist that took these pictures after they completed straightening the teeth. They are beautiful occlusion, beautiful teeth. Those gums look amazing. So everything about this person makes me happy. All right, moving on. Slide 52, dental class 2. Can you see this is a class 2? They need a filling. We see where it's broken through the dentin. It's not huge, but it's big enough that it needs to be filled. So they need a cleaning, maybe they need a filling, maybe they need a cleaning with the periodontist, scaling and root planing, oral surgery. Perhaps they have a tooth that needs to be extracted in the back, but it's not an emergency, like a third molar. So that's a dental class 2. All right, slide 53. Y'all see why the dentist is crying? This is my Vietnam. This is like I'm looking in this mouth and I'm questioning my life's decisions. So dental class 3 we would consider it non-deployable. Now the new terminology is deployable but not medically ready. Patient's likely to be a dental emergency. They're going to have pain. It could be an abscess, a root canal. They may need an extraction. They need to be treated. So we always keep our dental class 3s. We keep slots available in the clinic. So if I mark you as a dental class 3, you get access to care sooner. So I've used this before on people that are just say that they have a high op tempo and they're getting ready to leave. Maybe it's not truly a dental class 3. It's a little subjective, and I list them as a dental class 3 to get them taken care of quicker, give them priority access. All right, let's go to the next slide, slide 54. Let's compare these classes. So on the x-ray, do you see how it is to the nerve on the bottom left on that molar? That's tooth number 19 in the universal system. Yeah, on that bottom right, that is a deep, deep filling, probably a root canal, absolutely. Could be an extraction. Class 3 caries. Small ones we would watch. I don't even think that they would be a class 2. I would just leave them as a watch. But then up top, you see that distal of that premolar. That's tooth number 4. So if you were my assistant, I'd be reading out, hey, distal occlusal, because we have to approach it from the occlusal. Distal occlusal of tooth number 4, caries. mesial watch. So that's the difference between the dental classes. I hope that made sense. Now let's talk about the emergencies we see, and this is what we commonly see with dental class 3s. Periapical abscess, periodontal abscess, pericornitis, alveolar osteitis, and a dislocated temporomandibular joint. Moving along, I pulled this from a recent article, just kind of listing what the most common diseases require to medevac. So I thought it was kind of cool because it's telling you some of the problems that we see downrange and up to the point where medevacing people for dental, which is crazy to me. All right, so the most common things that we see downrange are cavities, pulpal conditions, broken teeth, and there it is, still number 4, third molars. And you can see the number of cases. And then on the right, because you guys use ICD codes, and I think it was ICD 8, is it 9 at this point? I think it's changed since then. But this was back during the mid-2000s that they did this, mid to late 2000s. So the number one reason that they medevaced was oral pathology, which could have been anything. That could have been third molars. Loss of teeth, diseases of the oral and soft tissues, and then there it is all by itself on number 5, third molars, as well as right above it, endodontic conditions. Pretty crazy. All right, slide 57. A contaminated root system can cause a sinus tract to form. Typically, it's not as painful at this point. You'll have a little pimple-like bump on the oral mucosa, and it may drain. You'll get that pus draining out. And when we test it with hot and cold, the tooth has no response. So this is the contaminated root canal system. And if you slide along through slides 58 and 59, it just shows a picture of the pimple bump on the oral mucosa. That's where the sinus tract is getting ready to drain. And on an x-ray, you see the black area around the root of the tooth. That's what it would look like. So this is a tooth that either needs an extraction or a root canal. Slide 60. So the word we use for that is a periapical abscess. Periapical abscess, because it's around the apex of the tooth. Acute inflammation at the apex of a non-vital tooth. Non-vital, meaning the nerve is dead. There's no sensation, the hot and cold on that nerve anymore. The etiology is typically due to bacteria and gross large decay. They'll start with pain on palpation, and then sensitivity when we percuss, when we tap on that tooth, swelling around the tooth and around where that abscess is going to drain. No response to hot and cold tests. Sometimes if it's systemic, they'll get fever and chills. So if it's systemic, I'm more nervous, and that's where I'll prescribe antibiotics. But if it's localized, there's no need for antibiotics. We just treat the symptoms as they are. So periapical abscess is the first thing I want you guys to lock into your mind. Take a look at the next slide. Radiographically, localized periapical radiolucency, widened periodontal ligament. And the treatment, numb it up, incise and drain, and then you refer to the dentist for an extraction or a root canal therapy. Unfortunately, if LISCO kicks off and you guys are in an area where you can't evacuate, you may be extracting that tooth. All right, so that's a periapical abscess. I don't want you to get confused with the next one. They kind of sound similar. Let's go ahead and hit the next slide. Periodontal abscess. So the periodontal abscess, inflammation in the sulcus of a periodontal pocket. So usually there's a pre-existing periodontal lesion, so there's a deeper than 3.5 millimeters. Remember, the 3.5 millimeters is key. So let's say that there's a pocket here that's 5 or 6 millimeters deep. Something gets caught in there. A foreign body gets caught in there. Popcorn kernels. One time I had someone who was using a toothpick, was digging with the toothpick and broke the toothpick off, got a periodontal abscess, swelled up around it. So you get swelling, edema localized to the attached gingiva and bone, so it's not at the apex. Gingival enlargement is lateral to the tooth. You'll get pus. The tooth can get mobile, but that tooth is alive, guys. It's still vital. It's not dead. Go ahead to the next slide. So radiographically, there's bone loss sometimes associated with the pocket, but it's not going to be all the way around the apex. Treatment will numb it up and clean out the area, find out what the problem is. And again, if there's fever, if there's systemic symptoms, then we'll prescribe antibiotics. Pretty rare with a periodontal abscess. Rinse, dilute, dilute, dilute. So salt water rinses help. And then just keep it clean. So that's the periodontal abscess. Moving on, slide 64, we're looking at pericornitis. Pericornitis is partial tissue that becomes inflamed. And it's usually that tissue around a partially erupted tooth. So it's all the way in the back around a third molar. The tissue gets inflamed and swells up. Usually underneath that tissue, there's food, bacteria just kind of stuck and living there. So you guys, I don't know if you can see it that well, but on that picture on the bottom right, you see how it's kind of like a pocket open between the tooth and the gums. So food and bacteria just kind of live in there, and it creates a small localized infection. You can get trismus, which is just the inability to open wide. So your mouth, you're not able to open very wide. You can get swelling. Of course, there's a foul taste. The foul taste is from the pus and the bacteria. Throbbing and pain. Yep, pericornitis. So next slide, you can see slide 65. So those third molars are never going to come in correctly. So they're impacted. I would call those both horizontally impacted or mesioangular impacted. Treatment, we will irrigate, anesthetize, try and remove trap debris, and extract the tooth. For you guys, your treatment plan is going to be irrigate, anesthetize, get them out of pain, try and irrigate it out. Sometimes it'll be swollen and you can do an incision and drainage just to get rid of that swollen tissue. You see on the bottom right slide, that x-ray, it's been impacted long enough that it's wearing through the second molar. So the third molar, where it's hitting that second molar, there's decay and a little bit of the tooth surface that is gone. So when this person finally gets this treated, they're going to lose both teeth. They're going to lose their second and third molar. All right, we are moving along on slide 66. Alveolar osteitis or dry socket, you'll see this a lot. It's almost pathognomonic, 3 to 4 days post-extraction. So memorize that. Someone's going to come in, they had a tooth extracted, now their bone is exposed, and it's painful. So the etiology is they lose the blood clot. The blood clot is what protected the socket and was helping heal. So when you lose the blood clot around an extracted tooth, it's painful. What causes them to lose the blood clot? Typically it's smoking, suction, and it is very, very painful. That exposed, unprotected bone is not happy. So usually what we do is we numb them up and we'll scrape the bone to initiate bleeding again and get a new clot to form. Most common around third mandibular third molar, 3 to 4 days post-extraction with pain and odor. I rarely see swelling and lymphadenopathy. It can happen, but it's rare. Next slide. So radiographically, you'll see a recent extraction socket. Again, the treatment, numb it up, irrigate it, and then usually I'll scrape it to get it to start bleeding again and form a new one, or you can use dry socket paste. Dry socket paste, I don't know that you'll have access to that in your kits. I don't believe you will, but it's got a little bit of antibiotics as well as like a sedative that'll help it feel better. Is there any function of dry sockets being more prevalent? And I mean, I have seen it more prevalent in some people, but usually it's because if they're diabetic, they're going to get it more often. Family history could be if there's a history of like a blood dyscrasia. Maybe they have some kind of a clotting disorder or something else going on. Also, you got to think like family history. These blood clots, you want to leave them alone, and everybody is different. Everyone has different eating habits, different brushing habits. So when they have their third molar extracted, I try and explain to people, you're not sucking through a straw. So no sodas, nothing that causes you to suck through a straw, no milkshakes, nothing that creates a suction in your mouth. You're going to want to leave this clot alone. You're not even going to want to brush it. So you want to leave that area alone and not brush it while it's healing up. You're going to want to start lightly rinsing, but you don't want to do that until almost a week later. So some people can't do that. They're absolutely incapable of not brushing an area in their mouth. Little OCD, I guess. I would probably be one of them. I have a hard time leaving it alone. But yeah, you will see this quite often in people who have their wisdom teeth removed. Our Coast Guard friends, I saw a paper they just put out, and they listed this as their #1 emergency in the Coast Guard stateside is dry socket after extractions. All right, we're almost done. Let me see if we can get through a couple more things and then call it a day. So the dislocated temporomandibular joint, we're in slide 68. This one you don't see very often. If you do see it, the people who get really excited and want to help treat it are our oral surgeons. The oral surgeons in the hospital love dislocated TMJ because they can, unlike the rest of us general dentists, they have access to IVs. They can, it's really hard for someone with a TMJ to swallow anything. So it's not like the pills or what we would normally give them to reduce their pain or a muscle relaxer. It's hard to do that, but the oral surgeons can give it to them intravenously. So a dislocated TMJ, go ahead and, the key thing from this slide is look at where it's at. The mandibular ramus has to be displaced anterior to that eminence. And I think I spelled it out on the next slide here, slide 69. Patient presents with a dislocated temporomandibular joint. They'll be locked in the open position. Condyle has been displaced anterior to the articular eminence. Appropriate treatment, usually, again, pain relievers and muscle relaxers, and then manual reduction of the mandible. So you put cotton on top of the lower teeth, and you will slowly push down and gently backward. So imagine them sitting in a chair and you're standing above them in front. You would put your thumbs on the occlusal surface of the mandibular teeth. That's why you have cotton on them. And you would slowly push down and manually get it to go back over that articular eminence. Again, I've only seen this a few times, and it pops back in. You don't have to push hard. It's slow, gentle pressure down, gently rocking back. And the oral surgeons love it. So if this ever happens and you're near a field hospital or an oral surgeon at BAMC, they're the ones who would love to put it back in place. All right, so management of lacerations. Let's go on to slide 70. I talked to you yesterday about how the vermilion border is key for injuries to the oral tissues, because that's where we'll throw our first suture. So when you got lacerations, we use absorbable sutures on the inner, and then we close the skin second. We suture at the vermilion border first. And I already talked to you guys about irrigation. You irrigate, irrigate, irrigate. Look for anything that's stuck in there. Slide 71, clean with saline and treat immediately. So this is a good thing that PAs can do. Y'all can be confident and just irrigate, irrigate, irrigate all the debris. If you see broken teeth, try and find those broken pieces, because sometimes the broken teeth will be in the laceration. Best way to get it to stop bleeding is to apply direct pressure. And when you close, again, close at that mucocutaneous junction, the vermilion border. Irrigate, remove all debris, and closure. Moving on, next slide, 72. Anesthetize, remove. You've got to treat the hard tissues first. So if we ever get someone sent to the dentist for teeth that are broken in an injury, we always want to make sure their C-spine and everything else is normal first. So in the hospital, the dentist is usually the last person after they've cleared everything else. Make sure that they're okay. This picture on 72, do you see the broken maxillary right incisor? So in the universal numbering system, that is tooth number 8. In the NATO international numbering system, that is tooth 1, 1. But you see how it's broken? So you want to dig around and try and find that piece in the lower lip. It's really helpful if they come in and they have the piece. Oh, this is part of my tooth that broke, and they have it in their hand. Okay, that's good. Now I know where it's at. And sometimes we can clean that off and glue it to the tooth. But yeah, you anesthetize, clean it out, and you're good to go. Next slide. Be conservative. The face is going to bleed a lot. That's pretty normal. Again, hard, direct pressure. Direct pressure is what's going to help it stop. Slide 74. Cleanse, cleanse, cleanse. Use saline. There's needle holder that we use to grab the needle. You don't want to grab it all the way in the back. You kind of grab it in the middle. Next slide. This slide I like to ask questions on. The classes of suture. There's collagen, synthetic, and non-absorbable. And then what I like to ask is about suture size, because it's kind of weird. The more zeros, the smaller. So the smaller the suture, it's easy to break. Like when you're throwing and you're tying knots, you'll see like with a 5-0 or a 6-0 or any of those really small ones, like the normal strength it takes to close, you're just ripping through the suture. So personally, I like the 3-0 and the 4-0 in the mouth. It's fine. It works really well. But if you're suturing tissue like that's going to be visible on the outside, you want to have a more delicate hand and use a smaller suture. Laceration closure, and then I think we'll be stopping pretty soon here. I know we're near the end. Start at the vermilion border, you do your muscle layer and absorbable, so like something that's going to be collagen or it's going to, absorbable material. And on the epithelium, you see how it's a smaller 6-0, non-absorbable. Avoid silk on skin because it's braided. It can cause some inflammation and scarring. 77. So, as a PA, would you close or would you not close? And I want you guys to be comfortable to go ahead and close. Close and handle what you can. Worst thing that happens, you close, you suture someone up and you get it to another higher level of care and they look at it and go, who sutured this? What a mess. And they cut the sutures out and redo it. That's probably the worst thing that can happen. So I don't see a whole lot of negative in y'all trying to rinse, and trying to close, especially when you think there's going to be prolonged field care. Next slide. Some good examples of what it looks like. Close with absorbable sutures, 5 to 7 days. All right, let's go ahead and call it a day. I'll answer any questions. We'll get to the dental trauma next time. Hopefully I can look you all in the face. It'll be a lot more fun. So we're on slide 79. We'll start there tomorrow afternoon. It is about 10 minutes till 1500. So I will stick around here and answer any questions that you guys have. Otherwise, have a great day, and I will see you tomorrow afternoon.